Good morning, everyone. So we will start our IC right now. The name of our IC is the Gizmo Geeks, turning us into Gizmo Geeks, the real-world application of the latest tools on the block. This IC is basically to discuss whether there are a lot of equipment available in the market in different fields of ophthalmology, to find out whether there's an actual need of them, or is it actually worth the hype. Our first speaker for today is Dr. Rohan Mehra. Dr. Rohan Mehra is a medical director at CKI Institute Saranpur, a consultant at Vision Eye Center Mumbai, and a director of My Health Card Private Limited. He's going to be talking on whether there is a need of Abrammetry in cataract surgery today. Thank you. Over to you, Rohan.
Thank you. Thank you so much, Dr. Nikhil, and thank you for having me part of this IC. It's always a pleasure. So I am going to be talking upon the fact that patients come to us saying that there are imperfections in the vision. So is there a need for aberrometry in cataract and refractive surgery? So often we get this situation wherein, of course, if there's a cataractus lens, we know what the diagnosis is. There is a cataract, we need to remove the cataract, and that will take care of the aberrations. But there are occasions when you do get a clear lens also in somebody who's maybe 40, 45 years of age, and you cannot explain why that person is complaining of imperfect vision. The second subset is when you have frequent changes of glasses. Now this can happen at any age to any person, starting from 18 onwards, where you have a case in where the patient says, I'm having frequent change of glasses, and you can do all your examinations, you can do all your tests, your investigations, and you're not able to find out why this is happening. So let's take a case example first. So 40-year-old patient, and he's complaining of difficulty in driving. And that's the only complaint that the patient has. You examine everything, you see that the patient has 6/6 vision, and this is how the slit lamp photographs look for the patient, wherein you are seeing an absolutely clear lens. There is no cataract at all. So you've got to don your investigative hat and go ahead and do an abrometry. Now, this is the abrometry of the eye trace. The eye trace is the latest tool on the block. The advantage that eye trace gives you is that it separately tells you the internal aberrations, and it separately tells you what the aberrations are on the cornea. So you know where the aberrations are coming from. Then of course it adds it up and gives you a total aberration also. So there is no machine other than the eye trace right now in the market that can actually do that. This is another example. So see, in the previous case, the internal aberrations were higher. So you know that more aberrations are going to come from the lens. So if you do anything to the cornea as well, it will not take care of what is happening internally over here. So you can do what you want to the cornea, you can do a surface ablation, you can put a contact lens on top to remove those imperfections. But till the time you know that you don't know that what is happening inside, you won't be able to give clear vision to the patient. Take this case an example. Everything is coming from the lens compared to what is coming from the cornea. Again, if I touch this cornea, if I say do a surface correction on this, and I tell the patient that your vision is going to be all right, it's not, because actually the problem is coming from inside. So let's take a look at what's new. So initially when the eye trace was launched, it did not have this. This is called the dysfunctional lens index, the DLI. Now what happens in the DLI is it needs to be as close to 10 as possible. The further away, that means the lesser it is from 10, the worse the dysfunctional lens index is. And there have been studies that have said that presbyopia is actually the first stage of cataract. So how would you justify operating a patient who is complaining of having a frequent change of glasses, having imperfect vision, without actually being able to document it in any way? This is especially helpful for insurance patients. Insurance patients who come to you and they say that, I'm not enjoying my vision. Then you can always document it by using this DLI feature and operating on that patient. You're justified on operating on that patient because you found out that this DLI is further away from 10 as possible. So from the cornea, in this particular case, I showed you initially that everything was coming from inside. So in this particular case also, this is how the patient is reading the E chart if you only take the cornea into consideration. The moment you start taking the lens into consideration, this is how the patient is reading. So the combined effect is, this is how the patient is reading. So although the patient might strain and be able to read 6/6, but actually that patient is not lying. This is how, some sort of an image, sometimes by some angle of incidence of the light, is getting made. So here's another example. It's 4.62, not as bad as the previous one. But still, you can see that the total eye, this is how the patient would be actually reading it. The other good feature about the eye trace is it gives you a potential visual complaint mix focus also. So it will tell you whether the patient is experiencing, according to the machine, according to how the algorithm is in the machine, whether the patient is having starburst or patient is having halos. The machine also sort of tells you. The other things are modular transfer function and point spread function. This also on multiple times. So at 1 month, 3 months, 6 months, when you take it and compare it, you'll get to know that these are the imperfections either on the cornea or on the lens that are causing the problem for the patient. Okay, so before the eye trace was launched, of course, we had the Zernike, wherein it was on the pentacam. Again, it would tell you differentially the type of astigmatism that is present in the patient's eye. Whatever the contour of the cornea, what is up, what is low, you could make out from the Zernike's analysis. This is something that I got, the 3D target geometry model of the cornea. Again, there are certain machines that give you this, but this is something that was there older. Now, you don't have to really go around reading this. Machine reads this for you and it sort of gives you a report. Now, coming to my last slide, which is the most important slide, and why we need Abrammetry in today's day and age, is this. You don't know what profession your patient is coming from. So 95% of the cases that you'll do, whether it's a refractive surgery or it is a cataract surgery, you'll be able to satisfy your patient will be happy. That's because in his day-to-day life, most of the time, he's all right with those imperfections of vision. But sometimes when you get, say for example, somebody who's a pilot, or you get somebody who's a cinematographer who has to work on the camera, or you get somebody who is from the army and he needs to do shooting. So those people you cannot satisfy them unless and until they have an absolutely perfect vision. So we have to be extremely careful in certain professions, what the occupation of the patient is, to find out what their imperfections in the eyes are, and the new tools on the block definitely help us. Thank you.
Thank you, Rohan. That was a wonderful talk. So do you feel that it is absolutely essential that in today's turn, for a newcomer, all of us here are young budding ophthalmologists, the need to have an aberrometer in our practice, especially if you're practicing cataract and refractive surgery?
So it totally depends on what gentry of patients you're getting. As I said, if you're getting people who are highly trained, highly skilled, highly qualified as your patients, then those people will pick up. So like for example, there was a patient who was an actor and he said, I need to pick up the warmth of the colors from the screen that I read in. And when I do an editing, there was an editor, I need to pick up those warmth of the colors. So if you get any imperfection into those visions, then it's a problem. If you're treating general, people who are not such highly skilled or trained into certain professions, then an aberrometer, like something as expensive as an eye trace, may not be necessary, but still at the end of the day, even a simple aberrometer would be helpful.
Thank you, Rohan. The next speaker for today is Dr. Tushar Grover, who is going to be talking about the need of corneal biomechanics. As Dr. Tushar isn't here because he has his own IC at the same time, I would like to play his pre-recorded video regarding the same topic.
Laptop audio. very good morning and my gratitude to Nikhil for having me in this really well thought out IC. And I'm sorry for not being there in the hall right now in person. I'll be talking about corneal biomechanics in cornea and refractive surgery. And to begin with, I'll talk about why we really need it. Now, we know that the cornea is not a piece of plastic. It exhibits the properties of viscosity and elasticity. And why is this important? Why do we need to know about these properties? That is because changes in these properties happens before morphological changes appear on tomography. So if we are able to detect a weakness in these properties early on, we can actually prevent the development of ectasia. And how do we measure corneal biomechanics? There are two commercially available instruments for that. The first is called the Ocular Response Analyzer, which uses a bidirectional applanation force and measures two important parameters called the corneal hysteresis and the corneal resistance factor. You see both these parameters being low in an individual who has a biomechanically weak cornea, which is somebody with keratoconus in this case. The limitation of this instrument, however, was that it was not sensitive enough to detect fine biomechanical weakness by itself, and it needs to be complemented with other diagnostic modalities. Also, the exact correlation of these parameters with the true measure of the Young's modulus is still not known. The relatively newer instrument called the Corvus ST is also gaining a lot more functionality now because there are a lot of updates that have been coming. So this uses a air puff induced deformation, which is tracked by a Scheinflug imaging device, which captures multiple cross-sectional images of the cornea. The parameters that you get in this includes things like deformation amplitude of the cornea, deformation amplitude ratio, and the radius of curvature. So in an individual with keratoconus who we know has a biomechanically weak cornea, you'll see a quicker first applanation happening, you'll see greater deformation amplitude, and also you will see a delayed corneal recovery in these patients. How is this relevant and how do we apply this? So if you have a patient like this, you see the tomography which appears relatively normal, except the fact that it's a thin cornea. So you would consider a surface ablation in this otherwise, but when you take into account the biomechanics here and you see that the deformation amplitude and other dynamic corneal response parameters are impaired as well, you would rather stay away from this case because you're definitely putting this patient at risk by doing any form of corneal laser vision correction in her, because it's not just the tomography being thin, but also the biomechanical parameters being abnormal. This, on the other hand, is again a slightly thin cornea, 500 microns, but when you look at the biomechanical parameters here, they're quite good, which indicates that this is a strong cornea and therefore a lot less likely to develop ectasia in the future. So you can definitely consider LASIK in this case and not just surface ablation. So with these different dynamic corneal response parameters, there was definitely value added, but it was felt that there was need for some normative data so you can compare these parameters to the normal population. So this was provided by the Vinci Guerra screening report. And apart from this, this also gave us the Corvus Biomechanical Index, which was developed using a linear regression analysis, uses some of the dynamic corneal response parameters that I spoke about. Apart from that, also uses a stiffness parameter and the horizontal corneal thickness profile. So this has been found to have a pretty high sensitivity and specificity in detecting cases of keratoconus. Following this, it was felt that there was a need to be able to integrate biomechanics with tomography. And that's where the tomographic biomechanical index came into play and was found to be useful. This has been found to have the highest sensitivity for detecting subclinical or formifaste ectasia. So what you see here on the right is a patient with a relatively normal looking corneal tomography, a pentacam scan. You can see that the BAD-D is also quite normal. But when you look at the tomographic biomechanical index, which is taking into account the biomechanics as well as the tomography, you see that the value is quite high, which indicates that this is definitely not somebody with a healthy cornea, and you would rather avoid any form of laser vision correction in this patient because this individual is at a risk of developing ectasia later on whether you do the surgery or not, but definitely more so if you end up doing a corneal laser vision correction in this particular patient. Now, I'll talk about some of the newer indices of corneal biomechanics. One of these is the stress strain index. The stress strain curve basically is not very relevant when you look at multiple individuals at one time point. This is relevant when you compare the same eye over different time points. So, if this curve is moving to the left, that means the cornea is becoming stiffer or stronger. Whereas if it is moving to the right, that means the cornea is becoming softer or weaker. The stress strain index is what describes the position of this curve. So if this value is more than 1, that means the cornea is showing stiffer behavior. Whereas if it is less than 1, that means it is showing softer behavior. And this is one of the first parameters that has been accurately able to indicate stiffening or strengthening after cross-linking. None of the other parameters were able to do that. The final index that I'll talk about is the CBI LVC, which is basically able to automatically detect whether the examined patient has a treated cornea, that is, has the individual undergone a laser vision correction. Now, when you look at the other parameters in these corneas, everything is going to be abnormal. So you don't really get much of an indication on the possibility of development of future ectasia in patients who've already undergone laser vision correction, whereas this particular index is able to do that. So it is able to differentiate stable eyes post laser vision correction versus eyes that are at risk of ectasia or have developed ectasia after laser vision correction. So to summarize, corneal biomechanics has definitely added a new dimension to our ability to detect keratoconus, and also in our ability, or also in our pre-operative screening for refractive patients, to detect the possibility of these patients developing ectasia later on. And corneal biomechanics combined with tomography is definitely the way to go. It has significantly increased our sensitivity and specificity in detecting ectasia and being able to predict ectasia. Thank you so much. Thank you for having me here.
Thank you, Tushar. That was really a lovely talk explaining the evolution of biomechanics over the years. I would like to ask a question to one of our panelists. Dr. Pavitra has worked extensively with the Corvus. I would like to take her opinion whether, as a refractive surgeon, is it absolutely essential in majority of the cases, or is a pentacam a device like that which gives you both the anterior and the posterior float good enough with the bad D to predict whether a patient post refractive surgery should be taken up for if a patient should be taken up for his refractive surgery or not?
So, from my personal experience, I feel that only in suspicious cases where we have doubt, wherein whatever few parameters, if they are in not very normal zone, in those particular cases, biomechanics will definitely have a very important role to play, but not for all the normal cases. So, I think in suspicious cases, it will have a role.
Thank you, Pavitra. So I'm going to be giving my next talk today. The practical need of the latest dry eye diagnostic tools and dry eye diagnostic and therapeutic tools. So we all know that there is a severe increase in the incidence of dry eye all over the world, and 35% of the world's population currently is suffering from dry eye. So what are the metrics that normally is available in our clinics to evaluate dry eye, being the Schirmer's test, the tear breakup time, checking the blink rate? You may do a fluorescein stain, a rose Bengal stain, you have the lissamine green staining, the OSDI questionnaire, and the Oxford grading. But none of these metrics can help us differentiate between what type of dry eye it exactly is. And hence, there is a need of a modern day diagnostic tool to detect dry eye. So here is the different kinds of modern day diagnostic dry eye tools available in the market today. So first, I would be just talking in brief about the Intraocular Surface Analyzer. So what are the different parameters that this tool can give you? One of them being the NIBUT, the lipid layer thickness, meibography, and the tear meniscus height. Now, in the meibography, what it does is with the help of infrared technology, it photographs your meibomian glands and tells you what is the exact percentage of the area which is lost in both the upper and the lower lids. Coming to the non-invasive breakup time, it tells you it's the time elapsed from the last blink to the appearance of the first random break in the circle on the ocular surface. So a normal would be anywhere about 20 seconds. In mild dry eyes, it would drop down to between 10 to 20, and in severe, less than 10. Finally, coming to the lipid layer thickness, it uses interferometry and detects the colored lipids on the patient's eyes and hence determines the lipid layer thickness. A normal one would be anywhere between 60 to 100, and anything less than 60 is a deficient lipid layer thickness. Now, this is important because if the lipid layer is deficient, there are higher chances of the tears getting evaporated faster from the eye. So, the pathology, you can differentiate between an evaporative dry eye or if it's an aqueous dry eye. And the tear meniscus height is the measurement that can be taken non-invasively. And here you take the measurement from the bottom lid up to where you can see the height of the tear. A normal would be 0.1 to 0.5. Now, in today's era, where people are having so much of unhealthy food, there is an increased screen time and increased use of air conditioners because people are cooped up in rooms and have desk job, the incidence of dry eye is definitely on the rise. And the current treatment of dry eye is definitely not good enough. People are giving blanket therapy just with drops, and that doesn't usually suffice for the patients. So, what are we know already that there is a role of warm compresses in MGD, where people take a wet towel and place it over the eyelids. But there is one defect in this, is that the heat is usually wicked away by the blood vessels, and therefore the amount of heat which actually reaches the meibomian glands is very limited. So then we decided it is better to have a multi-treatment approach which involves a lid massage, lubricants and topical cyclosporins, oral treatment if there is deficiency of any vitamin D, and the modern day treatment modalities. Now, talking of the different modern day treatment modalities, you could either have thermal therapy or an intense regulated pulse light therapy. The thermal therapy works by application of both heat and pressure and helps in the expression of meibomian glands. The IRPL, or the intense regulated pulse light therapy, stimulates the zygomatic nerve, which increases the parasympathetic outflow to the meibomian glands and the lacrimal glands, leading to the actual expression of meibum. Now, in thermal therapy, there are different modalities available, being the LipiFlow, the iLux, and the TearCare. The LipiFlow is the most common one. It usually provides not only pressure over the lids, but also a heat of around about 38 to 42 degrees. And this combined technique helps with the expression of meibum. Now, I'll just show you a short demonstration. This is how the applicator, in case of the LipiFlow, is applied to the eye. If you see, there is the heat provision is on the outer lid, and then there is a pressure also from inwards, therefore squeezing out the glands. So this is exactly how the LipiFlow would end up working. Now, this is the literature search where we see that how that LipiFlow treatment results in almost 9 months of sustained improvement in cases of dry eye. Similarly, we've seen that LipiFlow can be successfully used both prior to cataract and refractive surgery in patients of dry eye for the effective management of the same. Now, coming to IRPL, we have multiple various modalities like the EI and the iLight freely available in the market. Like I said here, what happens is you apply jelly below the eye, and there is an application of a xenon flashlight at 5 different points, 4 below the lid and 1 on the side on the temporal aspect. What happens here is that it stimulates the parasympathetic branch of the zygomatic nerve is stimulated, which then goes and stimulates these glands, that is the meibomian glands and the lacrimal glands, to open up, and hence there is a secretion of meibum. Now, usually the EI comes with a treatment protocol that there is usually 3 definite sessions required at 0, 15 and 45 days, and the effect is usually seen by the end of the first or the second month. If the patient is not doing well even after that, there can be a 4th optional treatment which can be given on the day 75. So what exactly happens is, because the meibum is expressed, there is an increased lipid layer and there is a restoration of lipid layer in these patients. Again, a literature search showed us that IRPL has successfully been used for treatment of MGD in multiple cases, and there is also the use of it to treat evaporative dry eye, and the people who are undergoing even cataract and refractive surgery have had a favorable outcome by the use of the same. multiple studies again proving the same, how their different parameters improve following a treatment with IRPL. So, in today's time, a multicentric approach of using both your normal topical lubricants and cyclosporins along with a modern diagnostic dry eye therapeutics can help and go a long way in the treatment of dry eye. Thank you.
Thank you, Dr. Nikhil. Just one question I had. You said that for the LipiFlow, one treatment there was a study that said it would last for 9 months. Practically, does it last for 9 months?
Definitely in our practice, we've seen that the effect definitely lasts for around about 6 to 9 months in most cases. Unlike the IRPL, where you need repeated sessions in that, at least 2 to 3 sessions is what is required. In case of a LipiFlow, a single treatment is usually good enough. Although it is an expensive procedure as compared to an IRPL because of the personal interface and things of that sort. But yes, definitely clinically, once given, it need not be repeated for at least of a period of 6 months. So the next speaker for today is Dr. Ashish Ahuja, who is the Chief Medical Director of Sadhu Kamal Eye Hospital. He is going to be speaking on the need of latest tools in the retina world.
A very good morning to everyone. I'm Dr. Ashish Ahuja. I'm a vitreoretina surgeon, and I thank Dr. Nikhil for including me as a part of this IC. So main focus of my talk would be on the application of OCT angiography, a newer tool in the diagnosis of and management of retinal diseases. So OCTA visualizes the retinal vasculature using motion contrast and for detailed analysis of the blood vessel structures in the superficial capillary layer, deep capillary plexus, and the choriocapillary layer in the retina. But as for other imaging modalities, OCT angiography is also prone to develop a significant amount of artifacts which are lesser now in the newer softwares and the higher versions of the machines available. So there could be cases where we get white line displacement because of patient blinking, or a stretch artifact which is happening because of the software which is trying to remove the noise and to process the image. The structures and the superficial layers of the retina may project shadows below it. So this is a report of a patient. Even the blink of an eye or small saccadic movements can induce artifacts in the images, which we should be aware of before interpreting the angiography reports. So this tool is very useful in analyzing the foveal avascular zone. So it has importance in picking up cases which are having macular ischemia, patients with a relatively normal looking fundus but vision not improving, or if a patient has macular edema post 5-6 injections, edema is not clearing, vision would usually be less than 6/60, so we have to suspect macular ischemia in such cases. And usually diabetics who have nephropathy, injecting a fluorescent dye might be contraindicated in certain cases. So OCT angiography is a very useful tool where we can pick up the widening of the foveal avascular zone and irregularity in the FAZ. So coming to some cases, you can see in this image, this is of an 85-year-old patient. On the fundus color photo, you can see that there is no clinically visible retinal hemorrhage, but just a grayish reflex seen on the fundus photo. The OCT is showing an increase in the central macular thickness with intraretinal fluid. So the OCT angiography done through the macular area is showing the presence of a Cnvm complex. So these patients will require anti-VEGF injections, And besides doing the OCT B scan, regular fundus, along with the fundus imaging, we can see that the neovascular complex is reducing in size over the subsequent injections, and this is useful in treatment planning. Coming to another case, this patient was having a Cnvm in a case of pathological myopia. Because of the very thinned out RP layer, such patients are prone to develop a Cnvm. This would be at a younger age as well, and this might be preceded with an exertion episode of coughing, sneezing, an injury to the eye, or lifting something heavy. The Octa will help in revealing the C-fan shaped or various patterns of the neovascularization, and this will help in treatment planning. Sometimes even the OCT may not be able to pick up, or in cases when we have a suspicion. So this is a very useful tool. Again, Octa can be useful in various vascular diseases. In patients with branch retinal artery occlusion, there is loss of the vasculature in the superficial capillary plexus, but this was a study in which they had shown that the deep capillary plexus was being restored sooner. So we can see the speed at which the recirculation is happening, and it will help to prognosticate certain diseases as well. In cases with, again, ischemic branch retinal vein occlusions, we will be able to pick up areas where there is capillary depletion and capillary dropout. Coming to cases of proliferative diabetic retinopathy, India being an endemic for diabetics and the global capital, so this is a very useful tool to pick up suspicious neovascularization, or many a times it will not be picked up on a routine slit lamp with 90D or fundus evaluation. So Octa will help in picking up small neovascular fronts, and this will help in treatment planning and following up of patients. The newer OCT angiography devices can provide a very wide field of view, almost 12 by 12 mm or even larger. So again, showing another case of PDR, the fluorescent angiography is showing increase in the fluorescence near the vascular arcade, and the OCT angio is picking up and delineating the structures very well. So even though we can't see the flow pattern or the increase in leakage of the dye which is picked up in an FFA, but the structure is delineated very well. Again, in a case of CSCR, these are usually younger patients between 30 to 50 years of age, type A personality, or who have a risk of smoking, presenting with blurred vision. OCT showing there is presence of subretinal fluid. Again, this CSCR is known to be a part of a spectrum now called pachychoroid disease, and this can progress over time for patients to develop a pachychoroid neovasculopathy or polypoidal choroidal vasculopathy. So such cases will also have useful implication of being Octa being performed in such cases in patients especially who have recurrent development of subretinal fluid in spite of doing an FFA, focal laser, controlling the risk factors. So we should suspect neovascularization in certain cases. This image is showing the effect of performing a focal laser after doing an FFA in a patient of CSR. So you can see that there is a loss of the choriocapillaries in the area where the focal laser has been done. Again, in macular telangiectasia, we can pick up the abnormal telangiectatic blood vessels in the area close to the foveal avascular zone, very typical of MACTEL. And these patients are also prone to develop a CNVM more at the later stage of the disease. So this can help in picking up the disease early, and the patients will have a good vision usually in such cases because it is parafoveal. Patients would maintain a 6/9, 6/12 vision, and if we can pick up the CNVM complexes and treat them early, we can help in preserving the vision in a lot of cases. So this is a useful tool, but the drawback again being the cost of the device, but hopefully in the years to come, the cost is going to decrease. There is a definite need for Octa in our clinical practice. It's a new tool with a great potential, and compared to FFA and ICG, which are the current angiographic gold standards, Octa has an advantage of being non-invasive. It acquires volumetric scans that can be segmented to specific depths. We can analyze the retina and the vasculature at a particular level. The Heidelberg OCT gives us even the intermediate capillary plexus, which is connecting the superficial deep. We can analyze the choriocapillary layer. So we can see en-face imaging. We can analyze a particular layer of the retina and study the vasculature there. This is giving more insights into the disease pathogenesis as well. The images can be obtained within few seconds. It provides the accurate size and the localization of the vasculature. Another disadvantage being, the inability to view the leakage which is happening from the vasculature, and there's increased potential for artifacts, which is reducing now as the softwares are being upgraded. This tool has been there now for almost 6 to 7 years, and the amount of artifacts are reducing now with the increase in the speed of the A-scans and refinement in the software. Thank you.
I think excellent presentation and very detailed. So just one question I had for you. So we've seen that in the past decade, the role of angiography has depleted. What do you feel it would be for the next decade? As you mentioned that it does not look very economically viable as of now. So if someone's investing in this machine now at the moment, do you foresee that in the next decade the role of that angiography is going to go further down?
See, role of angiography has reduced definitely over the past decade, but this is not going to replace the traditional FFA. Again, analyzing the choroidal vasculature is not that good at the moment, except for the choriocapillary layer. So certain diseases like PCV, we need ICG. We need to see the flow through the vessels, how the leakage is happening. But there is a lot of development happening in Doppler-based OCT, where they are analyzing the flow as well. That technology should also come within the next 5 to 10 years. But FFA and ICG for now are here to stay.
Thank you.
Any questions from the audience? Okay, so next we move on to our next speaker, Dr. Tanya Balakrishnan, who is the Chief Medical Officer at Arvind Eye Hospital, Madurai. And her topic for today's presentation is role of OCT in our glaucoma practice.
Good morning, everyone. I'd like to thank Dr. Nikhil Balakrishnan for giving me this opportunity. So let's quickly go through how to interpret a posterior segment OCT in glaucoma. So the key parameters have a color-coded scheme where green indicates a normal reading and red an abnormal. The RNFL thickness map is the actual thickness of the retinal nerve fiber layer, and it has an hourglass or a butterfly wing appearance in the colors of yellow and red. It helps to detect any asymmetry between the superior and the inferior sectors, and also diagnoses an early peripheral defect, which is noted as a blue notch in the red and yellow sectors. The neuroretinal thickness plot evaluates the neuroretinal thickness, which is measured from the extremities of the Brooks membrane, and it helps to look for an extensive notch. The RNFL deviation map, there is no color overlay for the normal thickness, but when the thickness goes below 5 percentile, it shows up as a yellow patch, and anything lesser than 1 percentile is shown in red. The RNFL thickness T is in plot. In normal eyes, it has a double hump configuration, and there's a color coding in which white is the thickest, green areas are the middle values, and red is in outside normal range. The RNFL quadrants are pie graphs which summarize the RNFL thickness T is in plots. Coming to the OCT macular reports, The thickness map again shows the actual thickness of the ganglion cell layer and the inner plexiform layer. The deviation map again has no color overlay, and the any thickness which is less than 1 to 5% is shown in yellow, and anything less than 1 is shown in red. The sector maps are divided into 3 equally sized pie-shaped sectors in the superior and inferior regions. There's a thickness table which gives us all the average and the minimum ganglion cell layer and inner plexiform layer thickness. The horizontal tomograph helps the interpreters know if the OCT is taken through the fovea, and any macular pathology seen on the OCT helps to correlate the pathologies in the OCT. Coming to clinical scenarios where we see how OCT has helped us in the diagnosis, progression, and treatment of glaucoma. So a 70-year-old male came to us to the glaucoma department with a best corrected vision of 6/9 in both the eyes. His pressures in the right eye were 32 millimeters of mercury and the left eye 20 millimeters. The anterior segment of both the eyes showed a nuclear sclerosis grade 1. Both the fundus appeared relatively normal with a cup disc ratio of 0.6. The HFA of both the eyes was within the normal limits. So what should we do now? Only the pressures are raised with no significant changes in the disc or the HFA. But taking an OCT, we can see that there is a thinning noted in the RNFL thickness map and in the deviation map. The key parameters show the values in yellow, which shows that there is a borderline change. And in the TSN map, we can see a slight dip in the inferior quadrant. Corresponding OCT macular reports also show thinning in the inferior region. So the case 1 was an early glaucomatous damage, which can be also called as a pre-parametric glaucoma, when there is still no functional damage on the vision field tests, but a high IOP and an early glaucomatous change was noted on the OCT. So starting an anti-glaucoma medication at this stage is advisable to prevent any further damage in the right eye. Coming to case 2, a 52-year-old female came to us with the best corrected vision of 6/6 in both the eyes. The left eye showed PXF material in the pupillary margin. The left eye fundus examination showed a 0.6 cupping with the inferior thinning of the neuroretinal rim. She was diagnosed with left eye pseudoexfoliation glaucoma and started on eye drop Stimulol BD and her pressures were maintained at 20 millimeters of mercury by using the drops. The baseline OCT, HFA showed a superior arcuate scotoma, but comparing the HFA at 9 months, we see there is a very small, non-significant change in the HFA. So do we continue the same medication or do we need to step up treatment? A GP analysis on the OCT shows that there is more thinning in the inferior sector, and also the thickness of the inferior sector plotted shows there is progression and increase of thinning in the inferior section. So this is a case of a moderate glaucoma with disc changes and a vision field defect, which corresponds to the OCT findings. But on a subsequent follow-up at 9 months, there was no specific change noted at the HFA. But since there was progression noted in the OCT, it is imperative to step up treatment to prevent further damage. Coming to the third case, a 40-year-old man with the best corrected vision of 6/6 in both the eyes and an anterior segment within normal limits, with the fundus examination showing a cup disc ratio of 0.5 with a slightly suspicious superior rim thinning. The HFA of his eye was normal, and the right eye pressures were noted as 17 millimeters per mercury. But on doing an OCT pachymeter, we saw that the CCT, the central corneal thickness, was 445. So the corrected IOP is actually 24 millimeters per mercury. And the OCT also showed corresponding thinning of the superior sector, as noted in the RNFL thickness map and the quadrant map. So this case was a case of a slightly suspicious disc with an IOP within the normal limits, but no functional damage noted. So the early diagnosis of glaucoma could easily be missed in such a case, but with the help of the OCT confirming the thinning of the RNFL and the OCT pachymeter giving us a clue of a falsely low IOP due to a thin cornea, we could start treatment early for the patient. Coming to the last case, a 35-year-old female with a best corrected vision of 6.6 in both the eyes had an IOP of 24 millimeters per mercury in both the eyes. Her anterior segment and posterior segment were within normal limits with a cup disc ratio of 0.3 in both the eyes. Her HFAs were within normal limits, so was the OCT. So why were the pressures actually high? On doing a pachymeter, we saw that a central corneal thickness was 599 in both the eyes. So the corrected IOP was actually only 20 millimeters per mercury. So in this case, although there was a raised IOP, there was no glaucomatous change or a field change. And since the pachymeter showed that the corneas were slightly thicker, it was just a falsely high IOP measurement. And this case was an ocular hypertension case, and we did not need to start treatment immediately and just follow up the patient. Thank you.
Great presentation. Actually, in the fourth case, I think the point that she made, we often tend to forget to take the corneal thickness, and we start the patient on anti-glaucoma medication. That's a very important point, most basic thing, and we tend to forget it in our busy practice. So next we have Dr. Pavitra Patel Balakrishnan, and she is a consultant at Saideep Clinic, and she will be telling us about mapping out before you start and the role of epithelial mapping for a refractive surgeon.
Thank you, Dr. Rohan. Thank you, Dr. Nikhil, for making me a part of this wonderful instruction course. So, good morning, everyone. The topic for my today's presentation is role of corneal epithelial mapping for a refractive surgeon. So, epithelial thickness mapping was FDA approved in the US in 2017, but awareness about its utility and in some minds its necessity was still growing. So there are multiple devices now available in commercially which are OCT based and which will not only measure the epithelium but also map the epithelium of epithelium. So of them, I'll be talking about two of the machines with no financial interest here. The first one is the Octo View, which is a spectral domain OCT and the first FDA approved non-contact quantitative measure of corneal epithelium and the stroma, whereas the new Revo FC Optopol has a AccuTrack, which has a real-time hardware eye tracking, which is an all-in-one OCT. Now, typically, the epithelium thickness will be 10% of the pachymetry, which is a thumb rule that we have learned. But it could be variable in different ocular conditions. Now, normally, the epithelium is significantly thicker inferiorly than superiorly and significantly thicker nasally when you compare it with the temporal epithelium. And it has a larger infero-superior difference than a nasotemporal difference. Now, according to the published literature by Dan Reinstein and group, when we look at the average pattern, there was a difference of around 6 microns between the superior and the inferior mean thickness, and there was around 1.2 micron difference from nasal to temporal region. So this is how the printout looks like for a normal epithelial map. The reliability rating here, it should be green and it should be good for the scan to be reliable. Now at the top we have the pachymetry maps for the right and the left eye, and at the bottom we have the epithelial maps. Now we have a color scale here at all the 4 areas like any other scan. Here green color is normal, red color signifies thickening, and more you go towards the blue, it signifies thinning. Now it gives us the corneal power, the pachymetry values and epithelium thickness in different zones. So this mapping is done within 6 millimeter zone, but now with modified RT view, it measures epithelium also in within a 9 millimeter zone, which of course has an advantage of a better resolution. So this is the print of a Revo FC Optopol epithelial map readout. The only difference here is that the Optopol machine scans the cornea in central 7 millimeter zone. Now, the knowledge of epithelium thickness distribution patterns may be crucial in deciding whether or not to operate the cases with suspicious topographies. This is because the epithelium is not evenly distributed over the Bowman's layer, and it is often non-homogeneously thinned, masking the underlying stromal abnormalities. So let us discuss a case example. Now this patient came for a refractive surgery opinion. He had a moderate myopia of around -3.5 diopter sphere with a -1 diopter cylinder, and topography was normal, as you all can see here. And on doing the epithelial mapping, we came across a very thick epithelium of around 84 microns in the right eye and 78 microns in the left eye. So this patient had both the options of either undergoing a trans PRK surgery or undergoing a femto-LASIK surgery. But now, if we had done the epithelial mapping and patient had if we had not done the epithelial mapping and if patient had opted for a trans PRK surgery, we would have used a value of average of 50 microns for this patient, and here under correction was inevitable due to the lesser stromal ablation because of the thick epithelium. Now, if we had planned a routine LASIK for this patient with a standard flap of 110 microns, again, under correction was bound to happen. Therefore, one needs to customize a planning for these patients, and this particular case emphasizes the role of epithelial mapping as a part of routine preoperative workup in refractive surgery patients to avoid under or overcorrection. Now, this again was a routine patient who had a IOP of 24 and 25 in the right and left eye respectively. We looked into the pachymetry reading and we got an incidental finding of epithelial hypertrophy for this patient. Also, this patient had a grade 2 nuclear sclerotic cataract in both the eyes. So if at all, leaving the IOP aside, but if at all the patient was planning for cataract surgery, treating the cause for epithelial hypertrophy, be it dry eyes, prior to the surgery will help in optimizing the cataract lens power calculation. Now, this is a published literature from Dan Reinstein and group who have beautifully described various epithelial thickness profiles for the diagnosis of keratoconus. Now, just for the ease of understanding, I have put few images here. This is the axial map and this is the epithelial map. Now, in the axial map, we should be looking here at the steepest point on the cornea, and then at the same point, we should be looking at the epithelial thickness mapping. Now, we can see the epithelium has thinned out in that particular area. Also, in this second scan, as you can see, we should be also looking for the compensatory epithelium thickening in the opposite side, like seen here in this image on our left side. Now, also here on the right side, we can see here, this is a typical donut pattern wherein the epithelium thickens in a ring manner around the thinning, which is seen usually in advanced cases of keratoconus. Now, this particular case is not directly related to epithelial mapping, but it's a very interesting case for discussion. So, this particular patient had a scarred bullous keratopathy since many years. And as we can see here, the central corneal thickness was around 750 microns and there was very irregular epithelium. So this was the fluid-filled cavity which was seen on anterior segment OCT. It covered an area of almost 197 microns from the epithelium. So we planned to do a PTK of around 200 microns for this patient. It was like a therapeutic PTK mainly to relieve the pain and by regularizing basically the corneal surface. So we had planned a ablation for this patient for about 200 microns. Cause the lower limit of the lower margin of the fluid filled cavity was at 197 microns. But because the scarring was diffuse, we wanted a 6 millimeter optical zone for this patient. And the moment you keep the optical zone as 6 millimeters, the maximum ablation that you can do at a time was only 50 microns. So therefore, we did 50 microns of ablation 4 times for this patient. Now, this was the thickness mapping at immediate post-operative period, which showed 460 microns of central corneal thickness. And we can very well appreciate the smoothing of the anterior stroma and the fluid-filled cavity, which is not seen anymore. So this was, again, the anterior segment OCT. Now, again, same findings, but this patient had deep stromal opacities here, which we can see clearly. Now, this was the 1 week epithelial thickness and the pachymetry mapping, which again showed which basically the patient was maintaining the corneal thickness of 469 microns and the epithelium had started to regularize. And this was the 1 week ASOCT. Now, the next case is basically epithelial mapping also has a role in patients who have undergone LASIK surgery. So, as we all know that the corneal epithelium, it thickens centrally and paracentrally after myopic LASIK, as can be very well seen in this scan. So, however, the extent of epithelial remodeling correlates with the amount of myopic LASIK correction done. So, to summarize, epithelial mapping will definitely change the way we assess the cornea. It has invaluable role in refractive surgery, pre-refractive surgery evaluation, and also complications. Also, when you land up in refractive surprises, you might want to look at the epithelium to rule out ectasia. It also helps us to monitor pre and post cross-linking outcomes, apart from detecting subtle cases of form thrust keratoconus. And it has a lot of other applications, like giving us information of ocular surface health, and also it helps in optimizing the IOL power calculation for these set of patients, and especially when you are aiming for good quality of vision. And lastly, it can also help in monitoring the treatment in keratology. Thank you.
So, due to paucity of time, we're just going to run through the last presentation. We have with us here Dr. Rituja Thomas Grover.
Yeah.
So, I'm really sorry, but we're really lacking time. What we could do is immediately after the session, we could discuss this over a cup of coffee outside, if you don't mind. Really sorry for the same. So, like I was introducing, my next speaker is Dr. Rituja Thomas Grover. She is a predominant oculoplasty surgeon working at Vision Eye Care at New Delhi. Her topic for today is, are you good as you look? Orbital diagnostics and cutting edge repair. Over to you, Rituja.
Big thank you to Nikhil and Pavitra for having me in this session. I know it's a little bit different from what y'all would have been listening to prior to this, but basically what I'm going to talk about is the recent advances and the gizmos which are now being used for orbital fracture repair. So a basic orbital fracture doesn't really require too much of effort or thinking. It's basically a simple procedure where you place an implant in the floor of the orbit wherever there's a defect in the orbital wall. Two-wall fractures require a little more imagination, wherein you can have flat or preformed titanium plates, which sort of have flanges for the floor and the medial wall. So these are the more complex ones. And nowadays, there's a 3D reconstruction model which you can ask for from your CT scan, the 3D reconstruction of the CT scan. The same can be given to you, and you can sort of mold your implant onto that, and then these are the plates and screws which the implant requires. So this is a patient in whom you can see the resolution of the enophthalmos once the implant has been placed. So this is how the implant looks on a CT scan, titanium implant once you place it, and you can see that it's nicely resting on the posterior orbital ledge. And this is an implant which is been used for the medial and the lateral wall. So in very large fractures with lot of disfiguration and almost total loss of orbital segments, you can see the maxilla sort of hanging there. You need a patient-specific implant, wherein you have a lot of enophthalmos because of disfigurement. You can see in the CT scan that the zygoma, maxilla, none of them are connected. So in these things, you need 3D modeling and patient-specific implants. So this is basically how the implant looks. It's exactly modeled based on the CT scan of the patient, and it is screwed into the orbital wall. So here you can see the pre and post-operative appearance. That sort of hollow is taken care of. And this is the post-operative image. So you can see how the walls have sort of joined together with the screws that have been used in the PEEK implant. And you can also use, like I mentioned, the patient-specific titanium implants, and this also gives a good post-operative appearance. So the advantage of 3D printing and patient-specific implants is that you can mirror the fellow orbit, you have a better pre-operative planning, and you can precisely match the contour. So what you need to do is basically send the company the CT scan, and they have the exact measurements, and they make the implant exactly according to the defect that you need. The limitation is there is a bit of a learning curve for this, and sometimes you need to trim the implant intraoperatively. It may not exactly sit with the optic nerve and things like that if it's too posterior. So patient-specific implants are the future in orbital fractures, and this is something that all of us are trying to work towards. The other thing is stereotactic navigation in thyroid orbitopathy. So it's basically a three-dimensional kind of real-time intraoperative navigation, which is a very expensive proposition in this day and age. So it's not something which all of us can afford, but hopefully the cost becomes less of a factor in the future. And now they've started 3D printing orbital implants as well. So this is something which has not yet come to India, but we are hoping that it does soon. And I'll just skip forward to fabricated custom ocular prosthesis. So hoping to remove the need of sending patients from near and far for getting custom made painted prosthesis, and hopefully it can be 3D printed based on their other eye. So I'm glad that we could do this meeting in person because it's really important to have social interaction, and I'm glad we could meet after 2 years. So thank you, Nikhil and Rohan.
Thanks, Rutuja. That was a lovely talk. I think you covered all the topics regarding the latest, what is latest in the block in the field of oculoplasty. I think if we could take a couple of questions, if the audience did have any, we can do that in the next 2-3 minutes.
See, sir, because the dryness, basically the cause of epithelial hypertrophy is usually because of dry eyes, which is obviously rampantly increasing. So at this point of time, definitely the epithelium thickness mapping is very important for us to rule out at least such cases, and before basically taking them for any kind of refractive procedure, if we treat that particular thing and then if we go ahead with the surgery, the quality of vision will be not compromised. Percentage, I cannot give you a value as such, but definitely it has increased, the abnormalities in the epithelium as compared to whatever previous decade.
I think that concludes the IC. I would like to thank all the co-instructors for having spared their time and being a part of my IC. Thank you, everyone.